Okay, good afternoon, everyone, and welcome to the March KPQC Learning Forum. Please enter your name and agency in the chat so we can keep track. And as we're just admitting people in from the waiting room, I will turn it over to Tara to get us started and make introductions.
Good afternoon, everybody. We're really glad you're here. Happy March Madness. If you remember a couple of years ago, we made an entire very creative play on words with March Madness, because in our world, that is not related to basketball. Welcome, and certainly know that you're in for a treat today. We are going to talk through data, which could be boring, but today it's not. And so I'm going to rush past a couple of high-level details that we do every month. But again, know that we want to dissect some important updated 2023 data as our entire focus today. Next slide, please. Ta-da! Oh, just kidding. One back.
Oh, it's not wanting to do this.
It's okay. Well, keep it on this one. You're good. So Carrie Smith, who's working on back and forward still, is the focus of our data today. You guys know that Carrie is a recent addition to the leadership team, but has been part of the 4th trimester initiative since its inception. Carrie now has really jumped full in. And she and I will spend 2023 using the data you're going to see to really work in depth and with direct TA with all of our sites. In fact, our goal is to add additional sites in the coming months. But today she will be your guest speaker. Before that, though, a couple rapid response moments. You all gave us phenomenal feedback about last month's learning forum, specifically around the mandated reporting conversation, DCF, perinatal substance abuse and its tie-in, sometimes, maybe, what ifs. And we heard so much positive feedback regarding sharing it out to all of your hospitals and agencies and colleagues. We also thought, hold on a second, let's bring this back and expand it. So you will see this as one of the agenda items for what used to be called our general meeting in May, but now we're calling it our conference. And so look forward to that and the full agenda that's coming out ASAP. Next slide.
Yeah, it's not letting me now, you guys.
There you go. Okay, you're good. So for some of you and some of us, we registered in a good, just kidding, side effect of the, it's okay, Carrie, we're good, I promise, of the AIM, of being enrolled in the National AIM bundle. We get information about some free online webinars, and that community of learning, the next piece, which you just saw, was in regards to creating rapid response teams and tackling maternal morbidity mortality prevention at the local level, specifically rural practice. We all started that last week, and I was impressed with what we're going to learn about. We are going to, those of us that are enrolled are going to bring that back to Kansas and talk a lot about what happens when you don't have an OB team in your hospital and you need to do a rapid response, or what does that look like to expand the rapid response that you already have in your setting to a more amenable, appropriate algorithm type response. So stay tuned for that. Also, before we go much further, everybody knows this face. Dr. Bettinger has been part of our team for quite a while, serving on our executive committee, being past chair, and we won't let her go far away. And this time I wrangled her in to talk about neonatal care. Why? Because we have avoided neonatal care completely because we've been focused on maternal initiatives for the last 2 years, and that isn't okay. If you remember, the Kansas Perinatal Quality Collaborative, our overarching umbrella group, which is what you all are part of, should be focused in on neonatal and maternal outcomes. And so I thought about this the other day and thought, who is the person who can jump straight in to that boat and start reminding us of the importance of hot topics that are going on regarding neonatal care and outcomes in Kansas. So our colleague's going to be here on April 25th for that learning forum to go through those items with us, and I'm excited about that. Next slide.
I clicked next. I think there's a little delay. So rather than click it twice, we're just going to hang tight for a second.
Let it happen. Patience is everybody in this call's best virtue, I bet. All of us medical people are really patient people, usually. Not.
I might hand this job back to Tiffany. Yeah, can you take back control, Tiffany? Because for some reason it's not wanting to advance.
All right, guys, a couple last minute things here, and that is our spring conference. Remember I told you, AKA general meeting. It sounds way more fun to have a spring conference. So we just all decided that's what we're going to call it from here on out. Save the date, May 23rd is going to be the date that we're going to do, again, our hybrid version. I promised I would never do this again, and look what happened. Just look what happened. So the entire membership is invited from 9 to noon. We will have many hot topics, and then jump in the afternoon to just in-person 4th trimester champions being present with us in the afternoon. So morning for everybody is invited. The 4th trimester champions will be on site with us in Topeka and stay for the afternoon intensive collaboration time. Membership wide will be from 9 to noon. And then I will see whatever slide comes up next and we'll go with it. Carrie, how can we help you?
I think Tiffany's reloading our slideshow.
Okay, perfect.
Can you see the screen?
Nope, all I see is you.
Okay, 1 second, guys. Sorry.
Technology, I tell ya.
Yes, technology.
Every
right.
time.
Can you see it now?
There we go. Okay, perfect. All right, well, I will just get this rolling then. And thanks for taking control of that, Tiffany. Good afternoon, everyone. I'm excited to have the privilege really just to speak to the reality of what we all know has been happening in our state nationwide, but we're really going to hone in on Kansas today. Since COVID, and now we have the data to support it. And the data is just going to support and further validate the need for all the initiatives that we're doing the 4th trimester and its importance. So next slide, please. So you guys have seen this slide over and over. I'm pretty sure we present it every time. And I'll tell you the same thing because I share this slide with all the nurses that we onboard at Advent Health Shining Mission. And that is that the bottom number on this slide should be 0. Women should not be dying from childbirth, not with the resources that we have. A couple important things to know about this data, though, is that this is the most recent data that we have in our state. Nothing further has been updated since 2020. And that tells us that we have a barrier to getting real-time access to the information that we need to stay on top of our information or on our initiatives. Also, I want you to note the definition at the bottom of the slide. They're acknowledging that these are the deaths that have happened within 42 days of the end of a pregnancy. That's important that we talk about because the next couple slides are going to cover what we've discussed several times before, and that there's different definitions floating around out there, which can become pretty confusing and conflicting when it comes to looking at maternal mortality as a whole. Also, I want you to hone in on the fact that we're really looking at the total birth number. Women who have stillbirths are still at risk. So every pregnant woman still has a risk, and therefore every woman counts. So next slide, please. That pregnancy associated death, what I want you to know from here, because we've talked about this before, is that is your big umbrella. And underneath that comes your 3 definitions: your pregnancy related death, which is those that are directly related to a pregnancy, the pregnancy associated but not related death, and your pregnancy associated but unable to determine. What's important about those is that these go out to a full year of the end of a pregnancy, not just the 42 days that we mentioned with the CDC. So next slide. Why that's even more important is that we are fortunate enough to have an MMRC within our state that does the deeper dive. Our CDC has access to death certificates, but it's not comprehensive, and they're only looking at those 42 days, like we mentioned before. But our MMRCs do the deep dives. They can look at the autopsy interviews, death certificates, birth certificates. With that information, they're able to get a big picture and further detail of exactly what the cause of death is. Next slide. Because of that, we know between 2016 and 2020, there were 105 pregnancy-associated deaths in Kansas alone. Due to the hard work of our MMRC, we were able to identify that half of those deaths happened after the 42-day postpartum period. So that's why it's so incredibly important that we're looking and doing the deeper dive so that we can truly identify what the causes are and focus our initiatives where they belong. Next slide. This slide, I know you guys have seen before too. Really what I want you to focus on is over here on the, I'm acting like you can see my mouse that I'm moving on the screen right now, but you can't. This just highlights those disproportionate causes that we have talked about, the birth inequities that are happening. We know that Black women comprise, non-Hispanic Black women comprise about 6 or 7.1% of the births in Kansas, yet they comprise 18.1% of the adverse outcomes. So that's a pretty significant statistic to focus on and just allows us to really hone in on, again, where our initiatives need to be. Next slide. Out of those 105 deaths, the combination of the underlying cause determined by our KMMRC and the underlying cause field on our death certificates are being used in order to categorize the type of pregnancy-associated deaths. So here we're able to identify that nearly half were related to medical causes, nearly a third were caused by homicide, suicide, mental health, and the remainder were by motor vehicle crash, fire, burn accidents. I think what we learned from this in a conversation I've had with Tara and Jill is really that our KMMRC has allowed us to see that a car accident can be more than just a car accident, that we can have women that are categorized as having a death related to a car accident, but once you dive deeper in and look into her notes, you'll see that maybe that patient has been to her OB's office 4 times within the last 6 weeks related to postpartum depression, or she's on specific medications due to it. Was it really just a car accident? Was this an intentional car accident? We're able to dive deeper in and identify that what we once thought was just a blanket cause has a bigger association related to it. Next slide. Also, there are determinations. These are our medically related causes here. And I think it's good that we're able to identify the additional relationships that we have: obesity's contribution, discriminations, contributions to our maternal mortality, the mental health conditions. We all know that that's a pretty significant one, and our substance use disorders and what they're related to. Next slide. I feel like even though we've all seen this slide numerous times, why I think this is important is because every conversation I had before joining on with 4th trimester with our nurses related to maternal mortality was really honing in on 25% of the case, causes are related to cardiovascular. Yet those are just our pregnancy related deaths. Those are those that were medically related just to the pregnancy in itself. And so it's been a big eye opener for me to realize that yes, cardiovascular conditions are relating too, but there are so many other contributors out there that that we need to pay attention to, and that we're pulling in all the other bodies within our community to help take action to help prevent moving forward. Next slide. So here's really the big meat and potatoes of what I wanted to highlight from this. Long before COVID, that maternal mortality was an issue. And then COVID hit and really, really did some damage. The COVID related fallout set us back big, pretty significant. And we we now have the data to show that. So next slide. In October, and I know Tara has shared this before in previous meetings, but in October of 22, the CDC released this report that really highlighted everything that we all saw was happening, but we were waiting for the data to support it, that maternal health outcomes were worsened and disparities persisted during the pandemic. We felt it. I know on the inpatient side, we felt it. I saw many patients come through our triage because our providers feared seeing them in the office if they had COVID. Many women were told, you're okay to stay home. You don't need to seek prenatal care right now. So it gave this false impression that they didn't need to access prenatal care. And it all just fed into worsening the conditions that we were dealing with already before. Next slide. The month of March has been busy for data. The CDC issued a report on maternal mortality in March and found that the rate of mothers dying while pregnant or shortly after birth increased in 2021. And to add to that, the rate of maternal mortality in Black women was more than double that of white women. We knew that Black women were 4 times more likely to experience adverse outcomes, but to see this, it just hit even further home to realize that the disparity is so prevalent and so big. Next slide. And then just this past week, the NIH published another study just highlighting that we also have a stillbirth crisis within our country too, that we need to take focus on, with stillbirths and maternal mortality shockingly high in the US compared with other similarly developed nations, and that Black women are paying the highest price. I'm happy to send out, for anyone who hasn't read any of the studies that I've mentioned, I can make sure that we share those out after this to anyone who would like it. So I know I'll get those to Tiffany and she can share those for anyone afterwards. Next slide. So these you have to click through one at a time. Sorry, Tiffany. The additional COVID-19 setbacks. We know that prenatal care visits decreased, as did our postpartum visits. We were lucky enough to get the patients in the hospital, let alone to think that we were going to see them after, especially with COVID. Our healthcare infrastructure was strained. I definitely felt that on the inpatient side. We had a huge increase in maternal anxiety and depression. Women were more vulnerable to loss of income during the pandemic, and therefore the struggle with increased childcare demands were exacerbated as well. We know our domestic violence spiked and the total percentage of preterm births increased as well. And then kind of going back to what I was just talking about, we know that we saw a significant increase in the total number of stillbirths that happened. In addition to that, next slide. We saw a pretty significant increase in our drug-related deaths in Kansas. And I feel like just looking at this slide alone can weigh heavy on someone, just looking at that huge spike. We experienced it personally in our family, and I know friends who've experienced it, losses in their families related to it too. We saw a 4-fold increase from 2002 to 2021 in the number of drug-related deaths in Kansas, going from 168 in 2002 to 679 in 2021. That's huge, you guys. I don't know who needs to sit there and just weigh on that. But again, I keep throwing all these different data points and factors at you as if we don't have one big issue we need to fix. We just keep highlighting the many faceted components here that are making it even more complicated and difficult to care for our moms within our state. Next slide. This is my favorite conversation to talk about because it's so personal to me. And I'm sure most, if not every single person on this call can relate to this, but let's talk about nursing. A nursing workforce analysis was published in April of 2022 that showed that the RN workforce decreased by more than 100,000 from 2020 to 2021. And I know that we tend to want to say related to that, oh, I think we just lost our slide deck. I'm gonna just keep chatting. I know that Many people want to say yes, but we had a lot of people retiring, or those that were close enough to retirement age might have just taken that opportunity with COVID to jump onto that. But the reality is most of those that left the workforce were under the age of 35. And I'm confident that nursing does not offer retirement at that age. So that should tell you that we had a huge problem. We felt the strain at our facility, and I've traveled to many different hospitals who are concerns that they have. In addition to that, over the past 5 years, RNs in step down, emergency services, behavioral health, and telemetry were the most impacted, with a cumulative turnover rate between 101 and 111%. You guys, that's huge in many areas, especially those OB desert areas who don't have obstetrics. A lot of those are their first point of contacts for your pregnant patients, where they go to first when they need access to healthcare. So if I, as a nurse, am trying to educate those who don't work in OB about obstetric issues so that they can also care for our patients, but I know that every 5 years, their entire staff is turning over, then that's going to greatly impact the quality of care that our OB patients are receiving. Not to mention, just not having the staff is a huge issue. In addition to that, I think I'm on slide 23 now, if that helps. I'm just going to wait since she's jumping on that. Perfect. We know that COVID amplified our insufficient staffing. We know that it raised the stress level of our nurses, it impacted job satisfaction, and drove many of our nurses to leave the profession. Just in 2021 alone, 29% of nurses in all license types were reported as considering leaving the profession, compared with just 11% in 2020. And most of that is attributed to higher pay as the most influential motivation to stay, followed by better support for work-life balance and more reasonable workload. I'm actually a little envious of our younger generation who's doing a significantly better job than I was taught, and what I'm doing at really balancing and prioritizing our work-life balance with just that overall balance. In addition to that, in March of 2022, a COVID impact survey found 52% of our nurses are considering leaving their current position. That's huge. 60% of acute care nurses reported feeling burnt out, and 75% reported feeling stressed, frustrated, and exhausted. We could probably talk about just this topic alone for hours and hours. And I'm confident that if I asked you to put in the chat box how many of you can relate to that, 100% of you would in some way, shape or form reply yes. So next slide, please. With that being said, how do we improve patient outcomes without the nursing staff to support doing it? How do you guys see this playing out at your facilities? And on top of that, next slide, this is where, in full transparency, I come to you and I say, I acknowledge that you have less, and we are coming and asking you to do more. We are coming with our initiatives and with our data, and we're saying, these are the problems, and we know that you're struggling. We are in the pits with you, but we acknowledge that we have to keep marching forward, and we have more on our plate that we have to contend with as a result of that. It's exhausting to ask it of you because I feel guilty and I know what that entails, but I also know that we are all in this insanely passionate about improving the outcomes for the moms in our state. And if we do it together, we can definitely succeed and accomplish this. Next slide. So to help you feel a little better, I just want to remind you of the things that we've already accomplished before we ask you to do more. I'm a checklist person who needs to see the light at the end of the tunnel. So if someone shows me all the things I've already done, then it makes me feel like anything is possible. So of the 30 of our participating facilities, 50, if not 75% of you are midway, if not a majority of the way through a lot of these projects. Next slide. With that being said, going back to that data that I discussed, remember half of all of our deaths are occurring after day 42. So when KPQC was looking at what their initiative had to be, they knew that they needed to make a significant impact specifically on the postpartum period. So they created a new postpartum care model. Part of that is going towards creating a standardized discharge summary. That's going to be the next step in our plan of what we're asking for the fourth trimester, is to ensure that every facility is making sure that every patient has a standardized discharge summary. Next slide. The irony behind that is that ACOG mentions this in their postpartum bundle, but hasn't formally put out an example of what that should look like. So we have ideas of what should be encompassed in that, but we don't have this grand model of exactly what that's supposed to look like. So that's part of our task, is we need to standardize the discharge summary form, but we need to know what that's going to look like so that we can ask all of you to do that too. So that just so you know, heads up on your plate, that's going to be our plan coming forward. And we will make sure that all of you have a copy of the ACOG postpartum bundle after the learning forum. Before we move forward, does anyone have any questions about this? Have you seen any in the chat, Tiffany? Nope. Okay. I know I'm a big data nerd, so I appreciate you all listening kind of as we just rattled through that. I'm going to turn this back over now to Tara and Jill, and they will take us from here.
I'm back. Actually, before we go back one slide, go back another slide. Tiffany, you're just so good. I appreciate back, forth, left, right. You're doing good. Carrie, nice job. See, you nailed it, my friend. I would love everybody really quick in the chat to tell us when she talked about the COVID related adverse outcomes. Please write in the chat if there was something you were surprised to see. Was there information she provided in the data that surprised you about the COVID, I'm going to call it backspin? I'm going to wait a second while I give you guys a few minutes to do that. Yeah. So if you're reading the chat, like I'm reading the chat, all of you, and I can almost hear your voices saying the things you're typing, which is even better. Please keep people not surprised, absolutely not surprised. Drug-related deaths, holy cow. We knew that was the nursing shift to leaving the field. We knew people were leaving, but we didn't know to that extent. Not surprised at all, Cassie, with an exclamation point. So why are we not surprised? I set you up with that conversation. I was surprised by some of the data that it was that bad that fast. So I would tell you that when Carrie was sending this information, because I do love her geekness, I was enamored by the fact that what we saw happening, and it doesn't matter if you were at the specific bedside or not. I would tell you during that time, all of us were at the bedside, because if you were at home, even if you weren't caring directly for a patient, you were caring for your family, trying to figure out how you all were going to stay healthy. So everybody was a bedside nurse, I would challenge us to think about. And so access to care, certainly disparities, no more so than racial. And those pieces that we knew existed just got amplified, right? Which is what Carrie showed us. I think there were twofold, just like with every problem, there's too many layers to really understand what the first level of data. And I think the first level of data said, hey guys, pay attention. There might've been a problem during COVID. And we went, there was. Second level of data we're just now getting, which says, not only did maternal outcomes as one example of a problem get worse, but it went way left real fast. And then the other part of that, of course, is the nursing. I'm going to call it attrition, but there was and not just nursing, guys. Of course, it was providers, it was radiology, it was lab, it was home visiting, it was all the pieces that had to happen, and the layers behind that. Carrie, you did a great job of the oversight. I would suspect we're going to continue to get data. It's just going to be delayed. And that's the hardest part about when we bring this to you. You know, Carrie said, well, wait a minute, don't you guys have updated data? And we said, here's the funny part. It's COVID delayed. Right. So yes, but it's not here yet. So long story short, you guys, Carrie, thank you. When I look at this slide and when I share this specific slide with this group and having worked with you all, but listening to Carrie's new eyes and Jill's new eyes on this data set and how we're going to get our state up a notch when we just backslid in the middle of a new initiative. We just went backwards. We're going to do everything we can on all of those checkmark items to make sure everybody in Kansas has all those things. It's the promise we made you a couple years ago. We're not going anywhere. So the stats are important, but we're going to go forward. Now, here's the hard ask that Carrie mentioned. She set me up. Slide 29, please. For those of you that are enrolled and those of you that aren't, we want you to be. So get a hold of us ASAP and we'll come talk to you or meet with you on virtual setting to get enrolled. For those of the hospitals and birth centers, now 30 strong, affecting 80+% of births in Kansas, we have to do a better job with our data submissions. The Terra Strota Word document isn't going to fly anymore. Though I probably asked you more than I even needed, I didn't know where we were. Now we know where we are, and we got to figure out specific data coming from our hospitals and birth centers. This is a really difficult to read because it's so small list of what the 4 trimester sites are going to need to start submitting on a monthly basis. Okay. We, Carrie and I and Jill are going to attack this on an individual basis with our sites and our champions. We do not need you to be overwhelmed. We do not want you to feel like there's an additional burden. We actually want to make this easier than the quarterly or monthly submissions that we've asked for before. Okay. So we will send this out. Tiffany, help me remember to give you the exact Word document to our champions. That just goes to our champions. You all will get this, share it with your data people, but don't do anything with it until we meet with you. So the rest of these few slides, you guys, are really for our champions, but for those that are thinking about enrolling, and maybe the data has been the reason you haven't, I would challenge you to think it's actually going to be easier, not harder, once we get you comfortable with the system. And what's the system we're going to use that's easier than Terra Strota Word documents? Slide 30, please. QHI already exists. One of our executive committee members, and it's getting bigger by the minute. Look at that. Excellent work. One of I call her our marketing guru. She's way more than that. Karen Brayman, I saw that she's on from Kansas Hospital Association. The president of Kansas Hospital Association recommended we use this program. And in fact, it looks to be extraordinarily helpful to us to gather data in a very simple website form. So again, I just want you to have seen it once, champions and hospitals and birth centers. We will walk you through the step-by-step. Next slide. This is a busy slide just to tell you the pieces and steps for each part and how you will get into the website and where you will put your data. And then slide 32, please. And how you'll put it in. So in other words, today, you would be, if you are from Stormont, Topeka, and there are 5 of you on this call, one, the champion or whoever's going to be putting data in would report in March of 2023 that there were 5 people that participated in a collaborative education moment. And this would count as one because it relates to the 4 trimester project. Okay. That's as simple as it is, as one example of the questions you'll be asked. Okay. Next, actually, that's the last slide, isn't it? Good. So what we're going to do next is divide and conquer, centered around data in Kansas, specific to your community, specific to your hospital, specific to your families, helping you to move forward. Next piece is that you're going to have more of us to contact with questions and troubleshooting. And then we're going to work with you again on data submission and get that fine-tuned so we can drill down into what this 4 trimester is putting out and show off your hard work. With that, I'm going to stop and certainly field any questions. You don't need to ask about the data. We'll come to you. But if we go back to any of the specific data related questions or just in general questions, we're going to give you some time back here today.
So Tara, Dr. Smith asked, what's the retention plan and plan to address the drug related deaths?
No, I meant the retention plan in place to retain nurses and the plan to address drug-related deaths. So I apologize, that was a compounded sentence and it may not have been clear.
Hey, Carrie, you want to tackle the nursing retention plan? And it's okay to say there isn't one, but I think we need to just say it out loud.
I know I was waiting for someone to have that magic answer, actually. I feel like, yeah, you're absolutely right. There isn't one. I feel like people are working around the clock trying to look outside of the box and think of different ways to entice nurses to stay, to retain. I think that answer is probably going to be different for every facility, depending on why the nurses are leaving that facility. We are struggling with that at our own facility. So I don't know that there is an easy answer for that plan, but if someone has that magic out there, please do share, because I'm open to hearing about it. And then in terms of addressing the drug-related deaths, it's a national crisis. The fentanyl crisis in the United States is pretty huge. And I personally would like to hear what is being done to help with that, because we're seeing it in more ways than we should be. So Dr. Smith, I don't have an answer for either of those, but I would love an answer for them too. I'm asking those questions right alongside with you.
Thank you so much.
Sorry, Dr. Smith, I didn't mean to speak over you. I was just going to say, if you look in the chat, there's lots of folks that are having input. I would say use the chat or jump on your mic if you have a conversation happening at your facility or your agency regarding nursing staff retention. I would also be really cautious with everybody. This is specific. That was data specific to nursing retention. We all know that radiology lab provide. So this is about medical entirety staff retention problems, or new hires, quite frankly, right? I mean, hiring and retaining are two separate issues, I think, too. To touch just really quickly, and then I'll get off the mic on the drug-related deaths. The Kansas Connected Communities group has paired with us since day one to try to tackle this problem. What we continue to run into with substance abuse work, with mental health, behavioral health, any version of perinatal mood disorder, all of those topics that feel like they connect or fall into drug-related pregnancy death, get stuck at the point of access. And quite frankly, in Kansas, we do not have enough providers for the number of concerns and referrals. So what we're working with in this next year at our hospital level is the point of discharge needs a warm handoff or an emergent response moment. And then who do we make sure that they're handed off to get adequate and timely help is going to be our finesse of the next year. That went backwards during COVID too, because less and less people were provider-wise were accessible. Jump on the mic if you have a plan in your facility for nursing staff retention. I'd be interested to hear if that's happening somewhere with some great incentives.
I think I'm concerned that it's not happening.
Tara, it's hi guys, this is Karen Brayman. Sorry, I was eating my lunch, so I don't have my camera on, but I'm with the Hospital Association. We actually have a workforce initiative ongoing. Our board, which is made up of CEOs from hospitals across the state, charged us last fall with dedicating more resources to addressing the workforce shortages in nursing, but in every role in the hospital, lab, rad techs, surgical techs. So we hired a workforce coordinator at the end of the year who's working on our workforce strategies. We've got making really good progress on a number of things. One is an apprenticeship program. We've been working with the governor's Office of Apprenticeships on an LPN apprenticeship program. We just got a letter of support from the State Board of Nursing last week, supporting the development of an LPN apprenticeship program, with the thought being that it would be a step in a career pathway that maybe starts out as a CNA or a patient care tech onto an LPN or RN, BSN, graduate level in nursing. We are advocating for funding during this legislative session for hospitals who develop apprenticeship programs. We also have a virtual career fair coming up on April 19th. I put the link in the chat. And we, so far, we have, well, this was a few days ago that I heard this number. It was almost 500 students who had enrolled to participate in our virtual career fair. I mean, it's for anyone, but we're targeting high school students and college students who are maybe haven't decided on a career path, and maybe healthcare career would be for them. So we've got a lot going on from the hospital association standpoint, but I would also be very interested to hear and what your needs are from your facility standpoint that we might be able to help with. And I'm going to also put the URL for our workforce page in the chat as well. Thank you. Sorry, I didn't mean to talk so long.
Karen, your driving force. What are you talking about? Jump on anytime. Who else? I see Mindy wrote some pretty interesting and awesome ideas for community healthcare system. Anybody else wants to jump on with some ideas they're doing at the local level? Yeah, if you're following the chat, the story of the bonus for new staff, but it's not always working. This is the fascinating piece of what works in your community, what doesn't. I love the idea that we're looking at high school kids to get them in and excited. And our own community has restarted our Medical Explorers group, and the amount of enrollees in our local CNA program has exponentially increased, which then becomes a feeder program, which is right. So we're all thinking of new and different ways. Carrie.
I was just, I'm going to add on to that too, just based on what you and I talked about the other day. I love that we're doing all these initiatives to get people in the door. I just want to know what we can do better in healthcare that that feels so broken to want to entice people to stay at the bedside. Like, that's great that we're offering bonuses. And I shared with Tara and Jill a story while we were on spring break. I came across a group of young nursing students in Nashville who were getting ready to graduate this May. And they had that look, and you guys know that look, that blissful, naive look in their eyes that was so full of energy and excitement for what they're about to encroach upon, and their passion for it. And I sat there feeling like I just needed duct tape over my mouth, like, don't burst their bubble, don't ruin it for them. Don't you be that person that tells them the reality of what they're about to walk into. And instead I thought, God, I miss that feeling of how I felt in nursing school when I was like, yes, I'm going to go out there. I'm going to save the world one patient at a time. And then you get in there and you realize there are so many broken pieces to healthcare that I can pull in all the nurses I want right now. But they're not staying. They're not staying at the bedside. The demands being put on healthcare, not just nursing, but on healthcare workers across the board, is so complex and so heavy. The burden that we've put on them is not matched by the return on what they get. And we have to fix that, or we'll just keep burning through expenses, onboarding new people. Like I put in that data there, every 5 years, these entire teams of staff are turning over. They're not staying. So if you're looking for what we could do, I think it has to be within the healthcare, the hospital systems, within the healthcare system. We have to fix the brokenness within that, because, yet you hear my dogs, I'm so sorry. Because we can bring all the new minds on board that we want to, but if we don't fix it, they're just going to leave too. Not to be the Debbie Downer, that sounds bad.
I'm proud of you for not hurting the nursing students' spring break plans, Carrie. You probably had some other ideas that what you wanted to do to help them too. Anybody else before we check out for the day? Great conversation today, and appreciate everybody's. We're all trying to figure out how to fix it, aren't we? Everybody is. Anybody else? Question, idea? Christy, when will you be coming to meet with us individually? I love it that you guys see, Carrie, they're not leaving. They want to know when they can start. They're ready to jump in. So we need to figure that out. The three of us are meeting in person on Friday to walk through next steps. So stay tuned, Christy. I'll put you first on the list. How about that? Okay, awesome. Yes. I don't know what we need to do for her. That's pretty, data is sometimes the thing everybody else kind of pushes away. You guys, you will get very quickly from us in the next, well, we'll just call it as soon as we can get to it, registration links for our spring conference. Please share that out amongst your listservs, amongst your colleagues, amongst folks that are interested in whatever piece of this puzzle they play a part. You don't have to be a medical person to be involved, but please also make sure that we get those registration links sent out. And again, for fourth trimester champions, you'll get a separate link. We'll make it really clear that you're in person that entire day. Same place as we've been. Sunflower Foundation's a great host, and how to do that. The conference agenda will be coming out. You'll get that information. So mark it down, plan to be there. And then we will see you all at our next learning forum and be in touch sooner than that. Have a great day, everybody.